Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Welcome back to the CoROM podcast. This week, we're going to be talking about the Austere Emergency Care course that we ran in Norway last week. With me is Dr. Tom Mallinson, is Tim Cranton, and Patrick Wenger, who are our faculty who are fully accredited and able to run the AEC course for CoROM. Welcome, guys.
Thank you. Hello, everybody.
Thank you.
Hello.
So tell me what you guys thought about last week. How was the experience for you, and what were the lessons learned, and what did you gain from this? Patrick.
Yes, for me, first of all, Norway, Horten was a great place. So thanks for all the support from the locals up there. For me, it was a really complex course. It came over nursing, critical care, tech. It was really complex and straightforward, and started up with the basics up to whatever management they had to provide in the scenarios. Great experience.
Tom, how did it go for you?
Yeah, I would echo. It was a great place to run a course. So that overshadows. You're just being in Norway is lovely. So yeah, I think it's a really good course. It covers that prolonged field care mentality and skill set, which a lot of other courses just stop and they say, and then you just look after them for another 4 hours. So it was nice having a course that addressed that. I think one of the biggest wins we had with that course was the international faculty and the international candidates or participants. I think that brought so much to it, and having both faculty and participants who were practicing at a really high level. So you could have a discussion of what do you do in your practice, what do I do in my practice, how do we apply that to caring for this person for a number of hours. I think we were really fortunate. And the course is set up for that, isn't it? Having a nice broad faculty and broad participants. I think that brought a lot to the course and to the discussions on the course.
I mean, that was an ALS only course. We can also run BLS and ALS mixed, which would be a different option. But last week everyone is very much high level. Tim, what did you think about the week, mate?
I think for me, the highlight was actually being in the presence of the people that wrote the PFC book. When you've got those people there, they have all of the expertise, they have all of the background, and you can talk to them directly about anything related to PFC. Again, these are the guys that wrote the script. So having the opportunity, to speak to them, for me personally, was really good. And again, I think really to echo what Tom had said, the fact that we had such a high caliber student group, that also made it really good. And they were at a high level of training themselves. But in saying that, despite their high level of training, prolonged casualty care, prolonged field care, austere emergency care was still a new thing for them. And you could see that there was still quite a lot that they needed to learn, but also wanted to learn. And they were a very enthusiastic group. So again, great faculty, not including ourselves, of course, but also a great student group to kick everything off.
And really nice to be able to introduce that bunch to the prolonged field care guidelines, which were clearly they're written for the military, originated with the military, but being able to get that civilian cohort, mostly civilian cohort, and say, look at these really good guidelines. What do we think? What can we apply? What can't we apply? It's just nice. You don't get that opportunity very often to bring that body of hard work and knowledge to a new bunch of people.
I don't know about the rest of you guys, but there was also kind of in between quite a lot of open discussion between the group itself on how they could apply those guidelines to their own work environment. Normally when a course starts off, you'll have students that, don't necessarily talk to each other or, are in their little group or clique. Whereas this group kind of surprised me, and they really gelled really quickly as a whole. So there was a lot of kind of discussion. How do you do it? How do you do it? Where do you do it? What have you got? Have you got this? Have you got that? They made also the course for themselves. I think that was important. But yeah, a lot of group interaction and a lot of shared ideas too.
We see that in a lot of the courses we run in Pretty Bay, where like the iCare or the TTEMs, where we have 14 people from vastly different countries and different skills to get cross-learning as well. It was quite interesting to see that last week. You're right.
I think the weather was on our side.
Except for the first day.
In terms of the austere part.
Yeah, all right, fair enough.
Patrick's used to that, of course.
Of course. But it's about the teamwork. After the second exercise we had, everybody spoke the same language. Even they're from all over the world came to the course.
I think it was a short space of time. You know, that 4 days, there's a lot of learning that has to happen, I guess, in that 4 days. But at the index, you know, our prolonged exercise, to see what I saw, I think, only within that very short space was actually pretty impressive. Again, maybe that's because of the student group as a whole and, you know, and their backgrounds and their abilities. But at the same time, to see that they, you know what, actually, if they had to leave here now and go through this scenario, we've got a pretty capable bunch of guys here. They'd obviously taken a lot within that first 3 days in order to be able to apply it on the last, you know, prolonged field exercise.
I think the design of the course, and talking to Sean about, he's clearly worked really hard on it as a course to make it work. I think having that first little injection of scenarios at the beginning really brought together the participants, really got them on the same page, really got them up and running. Because I agree with you, I think the challenge is getting everyone to work together in quite a short space of time. But I think that design element of early, on your feet, outdoors scenarios was a nice way of stops you gelling and just sitting in a chair and looking at a lecture, and got people talking, like really got people talking early on, and working together at the level they are all competent or expert at of caring for a patient. And I thought that was a nice design element, having that early scenario to then build on and then get them working as a team for later on.
I think it was a bit of a shock and awe.
Yeah, it was, and it was snowy that first day, wasn't it? So it was
like sideways snow. And 20 knots, 20, 30 knots.
Yeah, brilliant.
It was quite warm, though.
Yeah.
I liked it.
It could have been a lot colder.
Definitely.
You had a bunch of warm clothes on.
Yeah, well, I came prepared. I just heard Norway, so I brought all the warm clothes I have. And then it was too warm.
Looked like the expedition.
Yeah. Well, I didn't know what to expect from the course. I was ready for sleeping in a snow hole, thanks to Tim.
I mean, on a personal level, because I got there a little bit earlier, and this may be something for someone else who might want to go to Horton or Norway or whatever, with Sean and Andy and what have you, we managed to do the saboteurs route. We went up to Roykin. So there was history as well. There was background. And I think for me, when I came away at the end of the week, battered and bruised as I was, there's history behind prolonged care in the environment that we were in Norway, because it is an austere environment. And I guess locally they're kind of used to that. So maybe they don't think of it like we do as people that don't necessarily, work or live in that environment. But having followed the route that the saboteurs took with the heavy water plant during the Second World War, that whole endurance thing, the environment part, but having to be clever, having to be smart, having to be able to utilize your environment, that's all part of prolonged casualty care too. So I felt I had a kind of a nice lead-in, an introduction to Norway, which is stunning, it's beautiful, but also to the facilities themselves in Horton. And it created a mindset to be able to work in that environment. And again, fast forward to our final, field exercise, when we managed to do so many things in terms of, having to hike to locate a patient who was entrapped, having to, rescue a patient, and then having to go through those phases of care as well, the whole ruck, truck, house, and plane, but actually doing those elements, not just saying that we were going to do them or that you should do them in the classroom. We actually did it. In fact, I think we introduced another element, which is boat. So we had some extra. But yeah, all of those, being able to work all of those elements into the whole thing provided a massive element, and I think validity as well to the course.
A lot of these rugged areas kind of already do austere emergency care. Coming from Alaska, it's kind of they don't call it that, and there's no defined curriculum or approach that AEC and prolonged field care gives you. But in Alaska, it's common courtesy that when you leave a campsite or if you leave your own house, that you always have a fire built, ready to go with a match right there, not a lighter, a match. So anyone who is about ready to freeze can walk into any house in Alaska, know that they just walk right into past the kitchen, everything, go right to the fireplace. It'll be right there. They start it. And no one minds. And then they'll warm up, they'll save themselves, get warm, they'll leave, they'll build the fire again, leave a nice note of, hey guys, I here's my phone number, and this is just quite common in austere environments. And I imagine in Air Zermatt, Patrick, you probably have similar situations of being in some of these extremely remote communities. There is kind of built in, isn't it?
We have a lot of villages up in the mountain. If you are there in summertime, even when the weather is turning pretty fast, each month with R inside the name, like September, October, you can have a huge snowstorm. And so always be prepared. We have the mountain houses, the SHC cottages, and they always have an emergency evac for all the mountain high climbers and mountaineers that's going up. But it can hit you everywhere, as in Alaska, as a lot of other places. Imagine in Edinburgh as well. Not in Edinburgh, in Scotland.
We've got the same, Scotland. Yeah, Scotland's dotted with like bothies, little sheds in the Highlands, either for the game hunters, but also if you get lost, they're quite a good shelter. So I vote for Scotland as another good place for running AEC. Can be. I was going to say the weather's quite austere, but today it's blue skies and sunny, and I'm wearing a t-shirt. But it can be pretty inhospitable.
Well, we're running some APIS courses, some POCUS ultrasound courses in Scotland. We might be able to do some austere emergency care courses up there as well.
I'm looking forward to the alternative locations of Malta, because obviously now there'll be a much different environment in terms of maybe the heat and what have you, and terrain. So it'll be interesting again to see how we can apply this in Malta as well, and a different experience of maybe a different environment, different facilities. It'll be good to see how we can switch it up if we do it elsewhere in Scotland or wherever.
Challenging switching from hypothermia prevention to heat stroke prevention.
But these are things we have to think about, in austere care.
Yeah.
It's not just about the patient. It's also about the individuals that are expected to recover patients or the people that may be around the patient at that time before you as a medical professional gets to the patient or has access to them. Like we said during the course, you as medical professionals, we might not see the patient until the house stage. If we were a field surgical team or something similar, there are different points where we, again, as health professionals, may come into this whole scenario. It's not necessarily just the point of care stuff, point of incident, interventions. There are other things that, we may intervene along the line.
And then most of the prolonged care that we do is based in clinics in the college, just because that's where the majority of people are going to be working. But here in the AEC, it does force us to really solidify the 4 levels, the 4 stages of prolonged field care. And I found that pretty beneficial, that we can't be myopic and just look at being on a site off the shore, or being in a mountain area, or an austere clinic in the middle of Serengeti. That we do need to continue focusing on the fact that there's different stages of care with the 4 levels of prolonged field care. So I'm grateful this course does bring us back to the basics and start from there.
And, we did a rescue from a bunker. Then we had to hike through the forest. And then we had to stay in the forest because we were compromised in some way. So we had to wait for our transport. We then got on a boat. And then from a boat, we got into the back of a van. From the back of a van, we went into a lodge where even the students lit the fire. You just said earlier on about lighting a fire. Our students lit a fire to keep themselves and the patient warm. And then from there, we went into a building. So we had all of those places where these guys had to, okay, pack up, we're moving, and go to the next place in order to practice their care. And they had that experience on that last day. A lot of bases, I think, were covered, which is impressive in itself. And maybe that the location also lends itself to that as well, and the level of support. We had some really good logistical support during our AAC as well in Horton, and having that makes a big difference.
I was just going to say, I think it was so refreshing having a course where we actually, the participants took their casualty onto a boat, and then they looked after them on a boat. And then they took them into a van and looked after them in a moving van. And I was just thinking back to, I've gone on multiple inter-hospital transfer courses, which are specifically teaching you about transferring a patient, where we never cared for a patient in a moving vehicle. So you might spend a whole day doing a transfer medicine course without ever caring for a patient in a moving vehicle. And then to do ours, and as you said, we got them on a boat, we got them on a wheeled vehicle. The only thing missing was a helicopter or a plane. But I mean, there aren't many differences. It's just a bit more noisy and a bit more smelly. I think that was a great experience, being able to actually simulate that patient care in a vehicle.
It's not just special ops using boats either. I met my wife on Clare Island off the coast of Western Ireland, and sure, they get Rescue 112 to come in and collect someone, but it's Ireland. So very often you're going to have someone who with eclampsia or somebody who's acutely unwell, and they're getting on a boat. That's prolonged care, and getting on a boat and then getting into Rona where there's an ambulance, hopefully, maybe not. Maybe it's Paddy with his car. So practicing this is good for all levels of medical care. This isn't just for operational guys going out to Ukraine or somebody who wears a uniform, a camouflage uniform for a living. I mean, this is applicable to everyone. And this is what AEC does, doesn't it? It brings the concepts that we had in special forces and brings it up and applies it to the civilian world. It's exactly the same stuff, same situations. We're not carrying a long rifle, which thankfully we're not. So it was good to see the different stages we were using.
The boat that we used was a totally enclosed lifeboat. So 55-person lifeboat, which is exactly the kind of lifeboat you will see in an offshore oil installation, which is obviously where I usually work. But that scenario, I've arguably done in terms of I had a patient that had to transfer from a standby vessel. So one of the engineers had an accident, managed to chop all his fingers off. And the only way that we were going to be able to get him in onto the rig itself to be able to give him any treatment was to lower off our own lifeboat so that they could use their own fast rescue craft. So one of their ribs. They brought the patient across to the rig. We'd lowered down the lifeboat. So we did the transfer from the fast rescue craft into the lifeboat. I did some treatment in the lifeboat as it was being winched back up to the rig. And then we had to transfer from the lifeboat to the sick bay to helicopter to hospital. And I took the patient all the way in and handed him over in Great Yarmouth. I think Great Yarmouth, maybe in James Paget's, I can't remember. But it's been done, totally valid. It was funny on the day because I didn't expect to see an orange lifeboat come chugging around the bay. And then when it did, I was like, okay, I can put that into a real life scenario. So it's valid, completely valid.
Patrick, in Air Zermatt, are you finding multiple stages, or is the helicopter landing everywhere? Can you get someone on a polk, carry them out of the woods to where the helicopter can reach you?
It's mostly depending on the weather. We found out several places, even in gorges, in canyons, what's some of the most challenging places we facing with our in our operation bases. Forest, it's doable. Our forests in the mountains are not that deep. So, but canyons it is, and we have the weather that gives us the go or no go.
How long have you been kind of stuck on a mountainside or in a gorge or a canyon with a patient? Are we would you get stuck for a couple of hours, or is it ever longer than that?
Yeah, when you really hit the bad weather, you can go in by the helicopter, or you have to go in. It can be from hours to days. It depends.
Wow. And how much kit do you bring with you for if you suspect you're going to get stuck? Do you bring, like, how much food do you bring?
If you go in and you get surprised by the weather, you get surprised. Then you're there. But you have a helicopter with you most time. If you're landing, you can survive in a helicopter at night, and you don't run out of water in the mountains usually.
Sorry, Patrick, do you carry rations and stuff with you?
Yeah, we have some chocolate. I don't name the chocolate as marketing purposes. We always carrying chocolate with us. In the winter time, it's really busy. We just go to the base for the equipment for our backpacks, fly to the next call. We always have some chocolate with us.
So it's like Harry Potter. Anything goes bad, you get a little bit of chocolate and everything's grand.
Yeah, the weather changing fast. Don't know what to expect the next call. I mean, we have to refuel the helicopter. We don't fly for many, many hours, but weather's coming in and you're stuck at some place. And for when you go by terrestrial, we have certain equipment pre-packed, just adding some rations for getting food.
Correct me if I'm wrong, Patrick. You've had to use an air hangar before on your base because you couldn't get. I'm thinking of the Horn. I'm thinking of the Netflix series.
Yeah,
wasn't there an incident where you couldn't get the patient to hospital, but you had to do some treatment in a hangar?
Yes, but this was so the rock was on the glacier inside the crevasse. We took him out. Then to the truck was fancy, nice, pretty good helicopter. And then we went to the house for doing all the primary care because we were not able to, during this time to do everything in the helicopter. So we had to do an RSI, whatever the patient had needed in the hangar. And then finally, after stabilization, we flew him to the hospital. And that's all the phases through from the beginning until prolonged field care.
Definitely.
Till the end in the hospital.
Wow.
And this was cold up there, pretty snowy, a bit stormy. We were really happy that we made him into the helicopter. We weren't sure. I had some cases that you going in to go out, you don't know what's the time limit. So, but back to the basic that the instructors from the IEC told us, always improve your situation that you have on scene. If you have to stay there, start to build up a BVAC as soon as possible. And not when you're already cold, make it in the beginning. As soon as you get the patient up, make a snow hole to bring him in. And if the CPR isn't going, it is how it is.
Do you have Lucas machines?
We have corpals.
Corpals.
CPR.
Yeah.
I think we're swapping to the Lucas. I think we've got an auto pulse at the moment.
Yeah, we had them before.
I think we have similar considerations to you where we had to look at performance in cold weather and things. Because if someone's in the middle of a golf course in the middle of, autumn and it's just fairly chilly, some of those batteries just die super quick. We have to look at that for all of our kit, which is such a pain. No point in having something if as soon as you take it outside in the cold, it cuts its battery life in half. And another battery is like kilograms of battery or something.
Doesn't that kind of go under the principles minimum, better, best? In terms of what you can carry, what works, functionality in the environment that you're in. If you're saying, it's great having a machine that'll do CPR for you, but if the batteries don't work, it's no good. So you've got to do it somehow. But then again, it depends on what you can carry a lot of the time.
That's the other thing. Some of this stuff becomes a hindrance, doesn't it? You can carry all, you could theoretically carry all the kit you want, but if it adds kilograms to you, you end up walking along like a donkey with a bag.
What was the defib that we were showing off that broke down into various components? We did a show and tell.
Corpals.
Corpus.
Yeah. And it's modular and it comes apart.
That's the Scottish Ambulance chosen defib modular section.
And what do you have for a backup? So that's the best. What's your minimum?
So I carry an AED separately.
Oh, good. Which one?
I should know that because I've used it enough. Bright yellow.
Oh, right. The bright yellow yoke. Yeah, you're not losing cool points at all. So you have that as minimum, and there's a better and the best.
Minimum, but We're looking at the Cell AED. I don't know if anyone else has used the Cell AED.
It's for sale in your country, and I want one badly to try it out.
Super tiny, so I think they're about this big. Built-in pads, so you just crack the box and then you stick the pads on.
Yeah, it's a once-off though, isn't it? But for 150 quid or whatever it is. It's
once-off and can deliver quite a few shocks. I think it's like 18 shocks, 20 shocks. Hopefully by then you've either got another option or you don't need to deliver any more shocks.
But then again, if you are having to do that level of resuscitation in a remote healthcare environment, you've got to look at your post-resuscitation care. And arguably, that's the hardest part. If you've got a patient and you've got ROSC, you need to keep it. So there are other things that you need to be able to bring into play. And again, have you got those, and have you got the environment to be able to do it in? And
that also can look at a minimum, better, best. Minimum is fluids, and do you have the pressors? No. Or better would be wet pressors. We just have epi 1 to 1,000, and at best will be your whole dopamine, dobutamine, and norepi, and millerone, and all the sexy stuff.
But you covered that, didn't you, Tom? You did the pharmacology section on the course.
Yeah. So again, on that course, for people that haven't done the course yet, there's a nice section on using a drip, just a dripped infusion, counting drips, but having a bit of the theoretical background behind that. So obviously, how much you're giving, what concentration it is. But then you plug in a few variables to a calculation of drip rates in your giving set, concentration, and then you can pre-work out your numbers. So if you wanted to have the capability of giving a adrenaline, epinephrine infusion, you could plug the numbers into that calculation and pre-populate your dosing table, and then you can use drips per minute to give a fairly accurate infusion of whatever you wanted. And it was quite nice having someone else having already done all the maths behind the scenes, for that framework for you to plug in the numbers.
Is it doctors hate math?
It's definitely better. That's a better option, isn't it? So precisely the drug you're giving per drop versus the minimum option, which is the dirty epi. You just whack in your 1 to 1,000 epi vial into a bag and then titrate for effect. I mean, that's minimum, but we prefer to have better options.
I think it's that move from improvised medicine, which is struggling to do the best you can with whatever you've got to hand, with stepping up to prolonged field care, which is doing the best for your patient with what you've got to your hand. But you are meant to be there providing that care. So you should have planned ahead. You should have a SOP or a clinical guideline. I think it's that step towards professionalism, isn't it? Even though you're remote and rural.
Yeah, I find that the prolonged field care guidelines, the CPGs and the Austere Emergency Care puts a framework so you can think about this instead of waiting until you're in a rough situation without a lot of kit. By reviewing the CPGs on the JTS website, if anyone has not read through those, you're losing cool points. But having that thought process and then taking a PFC course or taking this AEC course puts this in perspective on this is the evidence-based medicine that you should be providing with the equipment that you have, minimum, better, best. It really lays it out perfectly. And it did for us in SF, and now we're showing this in the civilian as well. It works. And I think it was great to see the participants from around the world kind of solidify that. And by day 4, starting to say the same language, have the same concepts that Sean Keenan originally had in 2012 and 13 when he came up with this.
The demands for the CoROM field guide has significantly gone up as a result of the AEC course on public media, that's for sure. As you know, I've had quite a few requests and emails saying, how can I get a copy? How can I get a copy?
So John Clark has put a suggestion of we're going to republish that this year. So we're going to follow his lead, and we'll have that maybe on Amazon maybe this summer, as well as the online version. And version 3 is Jason Jarvis is our director of publishing, and he'll start allocating out a third edition. But yeah, it's really helpful. And Sean Keenan is creating an AEC field guide as well. with just the concepts of AEC. And I'm looking forward to seeing that as well.
It was nice to see some of, again, obviously we gave those students copies, but it was actually nice to see them using it as a tool, not being afraid to use checklists. My lead in there is, checklists are important when we're looking at austere emergency care and prolonged care to make sure that we're getting it right. And we did quite a bit on documentation and using the nursing care plans. And I think that's really important to make sure that, we maintain that emphasis on don't forget nursing care, don't forget your checklists, make sure you have a plan so that you can effectively manage this patient in whatever environment you find yourself in.
And I think those checklists, as you were saying, they stop you forgetting things or dropping them off. But I think they help you set priorities as well. Because then as a team, you can say, okay, guys, this is what we've done. This is what needs to happen in the next half an hour, the next hour, the next 5 hours. It lets you have that shared mental model of this is what we need to achieve in the next section of time. And then you've got a list and this is what we're going to do in the next 10 hours, but these things are the priority. I think a checklist makes that a lot easier as well and helps everyone be on the same page with that.
I think we need to implement more checklists in the 3rd edition.
I think that's super helpful.
Definitely. With a nursing care plan in particular, and being able to trend, obviously, all of the observations, but then having that list to go down. And again, on the final exercise, it was nice to see those guys were actually using that. There was a lot of, despite the fact that we were changing roles and responsibilities quite a bit to make sure that everybody had a go, they were still able to kind of pick up where the last person had left off and carry on with those charts, so that they knew where they were at any time in terms of the patient's care, because it was well documented, and so it should be.
Patrick, what kind of checklist are you using in Air Zermatt?
We have the protocols from our medical director, pretty good, pretty solid, but it's no PFC in it, not so far. We have our basic protocols like all over. We've extended, of course, different difficult airway pattern, hypothermia, avalanche, and specific for the mountains. I
wonder if we could adopt some of that for the college pocketbook.
Yeah, there's something we can talk to. Yeah, we'll talk to Air Zermatt of. They can have some of our field guides in exchange. We can take a look at their. Yeah, if only their medical director was a PJ and had a vast amounts of understanding of prolonged field care, it'd be lovely, wouldn't it?
Mm-hmm.
Well, we might have to extend an invite. Get him on one of the courses or something. Give him a taster.
Yeah,
you have to do one in Switzerland.
Yeah, I could see us doing that. Maybe after the Air Zermatt conference in February.
Next year. TBS 24.
Yeah.
I mean, that would be lovely.
Yeah. Also for me, I mean, it was the first course from AEC in Europe. So the seeds are done in the soil in Norway right now. But I hope the community, it will be a growing community. I'm sure the community will grow, and the spirit with all the points we discussed before will have a big impact. I already packed my ruck new, so I already had to roll over my backpack at home.
Wow. That's great. So looking forward, my question to you three, where do you see this going, or what applications can we use this, or what development can we have with the concepts of AEC and prolonged field care? Tom?
I think the question is, do we carry on using the military PFC guidelines? Because I think as long as you're playing a juggling act of, well, how appropriate is this for civilians? I think there's room there, hopefully, for the prolonged field care guys to create a parallel guidelines for civilians. That would be nice. And then I would see this guideline as an excellent CME or CPD course for anyone who's going to be involved in prolonged field care. And as you said, there's the ALS and the BLS versions. So I'm really looking forward to being able to run a course that's a mixed cohort of BLS, ALS, because I think that mirrors the world we work in. I think a lot of us work in that 2-tiered system or 3-tiered, where you've got BLS, ALS, and then some sort of enhanced care teams. So I think it would be really nice to start running some of those across Europe. And as Tim said, address the challenges of running them in different places for geographical challenges or, backstory of different geopolitical scenarios and stuff. I think there's so much that you can adapt the course to. So I'm just looking forward to running it again and seeing what we can do with it, and seeing how other participants find it. Because I think the lot we had on the Norway course really enjoyed it. I think it'd be nice for us to run another course and to just be better and to see what we can learn from each course we do. So yeah, I'm looking forward to more European courses.
I'm waiting for you, Patrick.
Yeah, I mean, the AC PFC, it's coming from the military, it's proved there. It will find its way into civilian life, I'm sure. We have really to work on the updates. The course will live. And with the community, with the next students that's coming up, new impressions, we will adapt the course from course to course. I mean, the concept stays the same. For me, it was bulletproof. The scenarios, we can work on it. The skills stays the same, more or less. And the charts, I think the same.
I think maybe there are some adaptations we may need to make to bring it into a UK European kind of scenario or life. There are a few Americanisms, I guess, in there. We talked about marsh, so I think maybe that's what you're reflecting to, Tom, the military side of it. When if you talk to everybody else, it's C, A, B, C, D, E, which is obviously what we use when we're using our own field guide. So in terms of that understanding, rather than having to, reteach. But then again, the group we had were pretty smart. So, I mean, they were able to relate quite quickly. But then if we were running a BLS and ALS group, maybe that won't be as easy. I'm not sure how it would translate. But again, go to what Patrick said. There's always going to be room for improvement, whatever we do and whatever course we do. And we'll learn from our students, and our students will learn from us, and we'll learn from the environment that we've conducted it in. But I'm definitely looking more forward to doing more. And I think we will find out more about the course and how we can improve it and how we can make it better as we progress as an organization. One of the things for me, I did the presentation part on nursing care, and arguably I would have liked to have spent more time on the nursing care aspect. But then that means spending more time in the clinic, which Aebhric had already said. We tend to focus things on the clinic because that's the environment we come from. But then to be able to give the guys a taster of all of the different environments they may end up having to practice this in, that was arguably covered by the course at Horton. So I don't know how we would replicate that, but at the same time, maybe put more of an emphasis on the nursing care side. Maybe the exercise has to last a little bit longer. And the other thing is, how can we get this into our BSc program? If we don't already, I know there are definitely aspects of it that we do. How we would introduce it into the program, whether that would come in year one. We kind of do it in the REMT, the 101 and through the 104. So I think maybe it has to come in at the first year, and then Tom, you have to maybe do a little bit in year 2, and then Vish, he does a little bit of it as well. He kind of rounds everything off in year 3. I don't know, that would be really nice. I really like the content, and I'd like to see that included in the BSc program if we could.
That's something we'll have to look at. At the moment, of course, PFC is in everything it permeates in everything we teach in all levels. Maybe not the ACLS course, but I'm pretty much all levels. Trying to bring in the 4-day curriculum into the Bachelor's Remote Paramedic program would be pretty easy, since we already have most of that content. We just solidify it into 4 days. But yeah, maybe Tom, in year 2, we could look at that as part of TTIM's course, or the advanced TTIM's course. We could look at that, and then they get the concepts in year 1. In year 2, they get the full 4-day AEC course. And as we do more and more case studies, we can incorporate, we already do incorporate the 4 stages, and we do prolonged field care. We just start calling it AEC instead.
I mean, ideally, you could put them through it twice. End of year 1 could be BLS AEC. End of year 3 could be ALS AEC. Clearly, there's funding issues there, but I think then you're visiting ruck, truck, house, plane, minimum, better, best, and then 2 years later, you're doing it again, but now you're the lead clinician, whereas before you were a BLS level clinician.
That's interesting.
I think that would be lovely.
And the other thing I think we need to take into mind different patient care groups, because we always tend to focus on adults when all we need to do is look at Syria, look at Turkey, kids, pediatric care, geriatric care. There are other patient groups that we maybe need to consider when we're doing this. Even on, we said austere emergency care, and this was an ALS class. Arguably, you could say, was it? Was it though? Because we didn't necessarily introduce elements like pediatric care or geriatric care or other, patient care groups. So that room for expansion. Goodness me, turn it into an MSc or something. I don't know, but that would be interesting.
Yeah, Masters of Austere Emergency Care. There we go. We're at 45 minutes, lads. We try to keep it under an hour. I know we can go all day. Patrick?
Just maybe to find a way to make the data collections that we can also get some feedbacks.
That would be an interesting study, wouldn't it? We could do a pre-post study on patient outcomes during scenarios before AEC and then after AEC. That's and Tom, we could do this in clinical practice as well. We'd get a bunch of paramedics from Northern Scotland, put them through an AEC course, and then see if there's any improvements in maybe not morbidities, but
but there's those nice studies on things like patients experiencing cold discomfort and cold stress, which would be a surrogate marker of your prolonged field care. If you can't even keep your patient warm, you're probably not ticking many of the other boxes of prolonged field care. It'd be nice to do, wouldn't it, to get a cohort of pre-hospital care providers, give them the course, and then pre and post. We just need a few £1,000s.
Yeah, that sounds like a challenge for any of our master's students and bachelor students looking for a thesis project to see what AEC will enhance and better the community.
I've been studying global healthcare and leadership today, so I don't know. Maybe now you've given me food for thought. How do I apply that globally?
All right. Thank you, Tom Mallinson, Tim Cranton, Patrick Wenger, for becoming our first AEC instructors. And we look forward to seeing what you can do in the future. Thanks for your time.
Thank you.
Thank you.
Cheers.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is CoROM, CoROM, corom.org.